Awesome. Well, welcome. Thank you all for attending this second installment of Strength and Unity. I am Luz Martez, and I serve as the volunteer manager for We Are Ill. And I was diagnosed with multiple sclerosis in 2019. So first, I also want to make sure as well to thank our generous sponsor of this event, Amgen. We're so glad you're all here to join us today. This space was created for us, by us, specifically focused on centering Black folks navigating NMOSD and chronic illnesses with care, respect, and real talk. Whether you're newly diagnosed, undiagnosed, but suspicious, longtime driver, a caregiver, or even an ally, you all belong here. Our goal today is really simple: build community, share truth, and remind each other that we're not alone in this journey. Feel free to use the chat to connect, affirm, or ask any questions you have. This is meant to be a safe and welcoming space for everyone. Take what you need, leave what you don't, and just know that you're seen, valued, and worthy of care. So we'll get started and pour into each other because there is strength in our unity. So before we fully dive in, I want to take a moment to acknowledge the incredible organization that brought us together today. We Are Ill. It's a nonprofit patient advocacy organization. It's focused to support, educate, and uplift Black women living with autoimmune disorders like MS, NMOSD, and lupus. Our vision is to redefine what sick looks like by making the chronic illness community more inclusive and by involving Black women in the conversations that we're not typically involved in around awareness, education, and treatment. Some of the main initiatives that We're Ill focus on is around really increasing Black women's visibility and access into patient care. Some of those examples of that includes diversity in clinic trials, wellness education, self-advocacy, and even like community. Some of the more popular events that we offer includes Wellness Weekend, our signature event that we host annually later this fall, where we bring together Black women all with various autoimmune disorders together in settings like this, but in person and virtual. Blogs from our influencers about how we live well in spite of MS. Even private Facebook group bring together thousands of women, Black women living with MS, and also community meetups across the country to help foster these strong connections on the more like in-person individual level. So I'm happy to introduce our moderator today. It is Dr. Jackie Nolan McEwen. We're so honored to welcome her. She's a fellowship-trained MS specialist and a board-certified neurologist at Joe Life Wellness Group, with degrees from Vanderbilt, Emory, and Philadelphia College of Orthopedic Medicine. Her path blends neuroscience, public health, and deep compassion for the MS community. Dr. Nolan McEwen also serves on the We Are Ill Advisory Board. She's trained at top institutions across the country, including the Centers for Disease Control and Prevention, and brings both cutting-edge expertise and lived experience to her work. Dr. Nolan McEwen is known for empowering her patients to take an active role in their care and for creating a space where collaboration, joy, and healing can thrive. So we know you guys are in good hands today. So over to you, Dr. Nolan McEwen.
Thank you so much, Liz. I appreciate that. That made me feel good. I'm like, is this about me? Well, welcome. So welcome everyone. Good evening. Good evening. I am honored to be here to share this space with you all tonight. Whether you're living with NMOSD or you're caring for someone or you're just simply here to learn, we want to welcome you and want you to know that you are a part of something powerful tonight. Before we get started, I do want to share just a little bit of additional things about myself. So I am also someone living with multiple sclerosis. Oddly enough, that's not why I went into neurology. I was already interested in neuroscience, interested in neurology. However, I had some imposter syndrome and decided to take a detour after undergrad, and rather than applying straight for medical school, because I was scared, y'all. I was nervous. I didn't want to be told no. I decided to go to and get my master's in public health. So that's how I ended up at Emory. But things happen for a reason, you guys. Literally on my first day of graduate school, I woke up and I had blurry vision in my left eye and was eventually diagnosed with optic neuritis. And then a couple weeks later, got my diagnosis of MS. The grieving process, so I get it. The grieving process was a lot. And had I been in my first year of medical school at that time, I probably would have had to take that year off and, start a year later. But again, things work out for a reason. And so I want you to know that I understand, and I'm really, really glad to be, even though we'll talk a little bit about the differences between NMOSD and MS tonight. I understand, and I'm again honored to be here. So everyone, let's just kind of get settled in. I want you all to be present, and let's take this time to really enjoy ourselves and learn and chat and talk, and really, get to know more about NMOSD and what we can do going forward. Um, so before we get started into the nitty gritty, I would like to introduce our speakers for the evening. We have both Monica Jones and Nawandi Williams. We'll start with Monica, but both of you, if you wouldn't mind kind of hopping on and telling us a little bit about yourself and sharing your stories.
Good evening, everyone. My name is Monica Jones, or Mo Jones, as most people call me. I am from Norfolk, Virginia. I had my first attack of NMOSD in June of 2020. Like Dr. McEwen, I also woke up with blurry vision in the left eye. Before the day was over, I was completely blind in that eye. Um, it felt good to get a diagnosis for that. I'd been having symptoms since as early as 2002, 2003. And to finally get a diagnosis, on the one hand, it's kind of devastating because, there is something wrong, but then you have that little piece of vindication because you knew something was wrong. You just didn't know what it was. Um, and I am also seronegative. So I have seronegative NMOSD as well.
Thank you for sharing. I'm really interested in, diving a little bit deeper into your story and, getting to your diagnosis and how that's impacted you. Before we get there, Nawani, would you mind introducing yourself?
Absolutely. Hey, everyone. I'm so excited to be here. My name is Nawandi Williams. I was diagnosed with multiple sclerosis in November of 2013. I guess I'm the third of the triplets because I too woke up one day and my vision in my left eye was totally blurry. I chalked it up to allergies and it just got progressively worse until I had no peripheral vision and they banned me from driving. So then I was like, okay, something's wrong. And so after a series of tests, a few weeks later, I was diagnosed with multiple sclerosis. So here I am. I'm also a licensed therapist. I've been a fully licensed therapist. I've been associate licensed since 2017, fully licensed since 2020. And I'm also the founder of my baby, my private practice called Release to Peace LLC. I primarily serve Black women because I love us. Um, okay. I through my schooling and my training, my post-grad training, I just really we just live a unique set of circumstances. And so I wanted to make sure that I was doing my part in making sure that I was providing a safe space for Black women to come into the real, the raw, whatever they need to come into a space with. So that's a little bit about me, and I look forward to continuing with the conversation.
Yes, yes. Thank you. And again, thank you both for sharing your stories. And I feel like, from as a therapist, you also have a unique standpoint. And I'm also we'll dive into this. I'm like already trying to jump into it, but just, does, the tasks and the skills that you learn through your training, does that change or did that help how you process things? I'm really fascinated to talk about that. But before I get ahead of myself, I want to take a step back and I just want to again name why we're really here. So everyone, we're here because Black NMOSD patients deserve spaces, like we mentioned earlier, that are made for us, by us, and specifically with us in mind. And when I say us, I mean Black women, Black males. I'm not sure if we have any men in the chat and stuff today, but we're all here together, and I want us to get grounded in that truth to learn a little bit more about the community and what's available out there. So again, to go over our goals for today. I think one of our key goals is going to be connection. I want us all to know that we have that community out here. That's another goal, is to help develop community, but to know that it's here. When I was diagnosed in 2009 with MS, there was not a community at that time with for Black women or Black people living with multiple sclerosis. I even did my thesis in grad school, kind of digging into the research, looking for that community, and it wasn't there. So thank goodness for Victoria. So I know a couple of years later after my diagnosis, I saw that Instagram post that she put up about We're Illmatic, and it went off from there. So sometimes it does. It's not, everyone is not someone that's going to step in and start their own organization, but for the people that is their calling, we appreciate you and we thank you for helping us to build these connections in this community. And then the last thing is we hope that everyone leaves today feeling empowered. So our goals are connection, community, and empowerment. So I want you all to leave feeling seen, heard, and better equipped to manage your life with NMOSD. So let's kind of move forward. Let's get the audience involved a little bit. So in the chat, can you all drop a word for us, one word that describes what community means to you? And I'll be looking down. While you guys are doing that, I'll kind of throw mine out. One word for me that I think of when I think of community is comfort. My community is, it's like that warm hug, a good, nice, warm piece of whatever dessert you like with some ice cream on the side. Like when I think of my community, that's what I think of. I'm comfortable, going to speak with them. I'm comfortable knowing that they have my back, that they have my best interest in mind, and that I can lean on them. Some other words we have safe. Absolutely, that's along the lines of kind of what I feel with comfort. We have another safety, support, togetherness. Yes, yes, I love that. I'm skipping you on purpose, Mo, because I want you to talk a little bit more about yours, but I see it in there. Trust, absolutely, trust. I agree with that. Okay. Well, let's move on. Let's kind of set our tone a little bit further. We want to hear some of this real life wisdom. I'm gonna get Nwandi and Mo, get you guys talking a little bit more. So this next conversation, I want us to feel like we're sitting back with friends, literally at the fireside, just kind of chatting and talking. Because I like the idea that healing starts with simply being seen and heard. So some of the questions I'll direct to either one of you, but feel free if you have something to add. Again, this is a just open communication. I want everyone to be able to say and speak what you need to. So the first thing that I want us to talk about is, when you hear the word community, what comes up for you personally? It doesn't have to just be one word, but what do you think of community?
For me, in a nutshell, like I said in the chat, is family. And usually within family, you find many things: safety, comfort, support. So I can wrap all that into that one word.
Agreed there. What about you, Nwandi?
Yeah, when I hear community, I just really hear safety.
Yeah.
Especially y'all are gonna hear me like Black woman y'all to death tonight, because I'm just like Black women, Black women. There's so many pockets in this world that just are not reflective of safety. And so when I think of community, I think of places that we can come to for refuge and empowerment.
I love that. Yeah, yeah, for refuge, empowerment. I feel like everyone kind of is thinking the same thing. Some additional words I'm seeing in the chat: dependable, safe place, to go along with with safety that other people were saying. So I think we're all kind of on the same page where that's what community and stuff means to us. Monica, how have you built or found your support network since your NMOSD diagnosis?
Um, So for me, at first getting the diagnosis is, especially when it's a disease that you've never heard of, like, people have heard of MS and lupus, but I had never heard of NMOSD until my diagnosis. So the first thing I did was Google, but there wasn't really much online by the way of like organizations, and it's mostly stuff telling you to expect to be dead within 5 years, So I just had to kind of build my own community at first. I did a lot of research. I did a lot of looking into what some of the different symptoms and things that I could expect were. And then I also told myself that life is going to be a little different. So at that time, I had found a hobby of making candles, and I was like, well, maybe I can turn this into like a career because going back to work for me is going to be hard. And I know that I'm going to need something flexible. So if I'm working for myself, that's a way to get into it. So I did pretty well with my candle business. The local newspaper did a story on me and talked a little about NMO, and then from there, community kind of found me. I had people reaching out from different organizations asking me if I wanted to. I started off writing articles for Health Union. And then from there, I ended up meeting people from the Guthrie Jackson Foundation, which I'm an advocate for. And then that's just kind of where I found my family.
I love that. I love what you said about community found, like your community found you. A lot of people don't, I guess can't necessarily say that, or it doesn't happen like that. But I think in the age of, social media and things of that nature, that is more something that we're seeing a little bit more. I definitely want to talk with you a little bit more about what your community specifically looks like. But before we get there, Nwani, can you tell us a little bit about what does a strong support system really look like for someone that's newly diagnosed with any kind of condition, chronic condition, neurologic disease, and how important is it for you to have one?
Yeah, that's such a complex but such a necessary question. I guess to answer the second part of the question first, it's extremely important. Being diagnosed, as we all know, with a chronic health condition, there's like the initial shock, then you go through there's grief, there's like confusion, lots of isolation. And so it's very easy to kind of slip into, feeling like you are all alone. And so I think that being able to, whether you find your community or your community finds you, I think it's super important because I think it can reduce, it can drastically alleviate those feelings of depression and anxiety. And most importantly, I think having good community can also remind us that it's okay to rest and that we don't have to figure all of this out right now, and we don't have to figure all of this out by ourselves. And so I think strong community, of course, your friends, your family. I'm a huge advocate of seeking like professional mental health support as well. So and I know we're going to get into like doctor's visits and stuff, but like ask for a referral. Hey, I'm gonna probably need some mental health support. Let's go ahead and jump in there so that we can go ahead and start addressing the very real and valid grief that comes along with being diagnosed with any kind of condition.
Absolutely. And how did you, what was kind of your approach to processing your diagnosis and going through your stages of grief? I know it's different for everyone, but what was it like for you?
Yeah, I'm gonna be real. I was in denial. At first,
Okay.
I was in denial. First of all, I had the doctor who diagnosed me. She had no bedside manner. So it was like, girl, you got MS. So what you gonna
Mhm.
do now? And I'm like, what is that? So
Wow.
it was like that initial, like, I don't know what to do. And so I was walking, it's like my brain just kind of like went into survival mode. Like I said, I had optic neuritis. So I also had, in the process of getting my diagnosis, I was also going through a round of steroid treatment. I was going to work with IV ports in my arm, y'all. That's how I was like, no, like, I don't know what this is. I don't have time to do with this. So that was that's just my real start, right? To like my process of MS. But now, if I'm being honest, you guys, I still grieve. I still
Mhm.
process. Sometimes I wake up and I'm like, I got this. And some days I wake up and I'm like, I don't got this. I need help, And so I think a lot of this is just being honest with where we are and being able to recognize that we can show up in the fullness and the range of emotion that comes along with um, having a chronic health condition. So that's kind of how I
Absolutely.
process. I just show myself lots and lots of grace.
I love that. I love that. Showing yourself grace. Absolutely. I think
Humbling.
for me, my process was similar, and I threw myself into learning as much about MS as I could, and doing different things. So absolutely, everyone is going to grieve different, and literally, it's just been a couple of years that I'm even able to kind of have conversations like this and tell my story without crying, you guys. So for me to even be able to kind of moderate and do, be on platforms like this even 5 years ago, I didn't know that was in the cards for me. So it's an ever evolving kind of process. And I don't know if any of you were at Wellness Weekend last year. I did a panel with another local Atlanta doctor, Dr. Jackie Rosenthal, and it was supposed to be from like we're real close friends, and I was supposed to take more of like the patient aspect and her as a provider, and just we're having that conversation, and she asked a simple question, how are you doing? And y'all, I started crying. I was so embarrassed. But I compartmentalize, and I get so into the Dr. McEwen aspect of things that sometimes I forget about Jackie and my condition that I'm dealing with. And I feel like a lot of times I'm not outside of my appointments, I'm not asked as much, because I guess people are like, oh, but she knows she's fine. If she wasn't fine, she would let us know. No, I'm a horrible patient. Well, not as much anymore, but I used to be a horrible patient. So, that it just kind of reminded me that regardless of where you are in your process, it's important to kind of take a step back and just kind of process, like, how are you really doing? Monica, did you have any other kind of ways that you went about your processing and grieving when you were diagnosed with NMO?
Um, I think I'm actually still in my grief period.
Fair.
They never really tell you about that. That's not something that's really talked about is the grief. And I don't think everyone grieves right away either, which I don't think I did. I think I just kind of jumped into, okay, life is different and I got to make changes rather than taking the time and processing what was going on. And I regret that a little bit now, because I think now it's manifesting in ways that are probably not the best type of behavior. Um, but it's I'm still working on it, but I think community has helped a lot.
Absolutely. And from the chat, I see Claudette Roberts said she agrees, kind of, she said still there for her off and on. So I think that's something that we're going to see across the board with everyone, where um, it's not like a cycle, or I guess it's not like you don't have a specific start and an ending. Like, it's this cycle. And sometimes you'll go through that cycle a little bit quicker, and then sometimes that circle gets a little bit bigger and you're in different stages of your process. But it's all fair, and don't be too hard on yourself, Monica. But that I think it is also important to kind of be mindful of different things. You're like, well, maybe I should kind of handle this a little bit different, or I'm doing good over here. Let me keep this up. So that's awesome. So kind of sticking with you a little bit, Monica, can you tell us a little bit more about what your support system actually looks like? Who do you really turn to keep you uplifted and to help you to feel supported on those hard days or when you're feeling a little down, that you might not be doing things the best way yourself?
Um, so when it comes to like being close to home, I've got my husband and my children who are the most help, and then also my sister and my two best friends. So those are the people that I know that if I don't feel well or I can't push through, that I don't have to explain. It's a, you're good. You can't do that with everybody. Sometimes if you're a little too tired, but it looks like you haven't done anything, you have to go into a whole spiel about fatigue and everything else. These are the people that I know that I don't have to, I can just say I'm tired and that's it. And my children are a little older now, so they're more help. So without me even having to say that I may be going into a flare or something, they can look at me and tell, oh, mom's not feeling the greatest. So they'll ask me if I'm okay, if I need anything. They try to be more mindful of their messes and things like that. Um, but as far as for people who can truly empathize and sympathize with what I'm going through, that support has come to me from the Guthrie Jackson Foundation and from the people that I have met through that. Because they truly understand. If I've walked 2 minutes and I'm like, I've had enough for the day, they're like, girl, me too. We be walking the same way, trying to find somewhere to sit or, whatever the case may be. But I think it's good to have that type of support, the support from the people that are closest to you, that you can be yourself with, but also the people who are in the same boat and can really understand what you're going through and they really know like how you feel, like I said before.
Absolutely, absolutely. I definitely feel that that is the perk of communities and organizations like this. Is why I was really excited when We're Ill decided to include NMOSD, they're in the organization, and even lupus. I know they're doing some things with Black women living with lupus. I think it's really important again to have that community. So from a therapist standpoint, Nwandi, what would you say are some of the benefits of leaning on community versus maybe trying to handle it by yourself?
Yeah, um I think Monica's demonstration or the story she just told really just paints a picture of the importance of community. Being able to, I think it can build like emotional resilience. It's a reminder that, okay, I can accept like, any limitations I have or adjustments I have to make and still know that I have a place to belong or I still have people who love me. I don't have to, I can make these adjustments and still be loved and still be cared for. And so I think that's just a super important reminder of, why community is so important because like I was saying before, it's very easy to slip into isolation. A lot of people don't understand. They just don't. They're like, what is multiple sclerosis? What is NSOD? It's just like, okay. And so to have support, they don't necessarily have to understand what you're going through, but they know how to show empathy. And so they know how to say, well, we can hold space for you as you figure it out and let us know how you need us to support. And so I hope I answered that question. Sometimes I ramble, but those are the benefits, I think, from a therapist perspective. Being surrounding yourself with people who care and community, really, really helps alleviate like just classic depression and anxiety. Every study shows that to be true.
Okay. Yeah, I love throwing in evidence-based things. I
Yes,
love
like,
that. We have studies that have proven
yes.
this.
Any study you find about community, gratitude is another thing. Like it
Okay.
literally rewire the physiology of your brain. It's just,
Wow.
yeah. So
That's fascinating to me. It's really fascinating. So still sticking with this whole community thing, what would, but for this is for both of you, what would you say that, what's community healing mean to you? Like, how can we, I say healing, how can we foster that for Black women that are living with NMOSD?
Um, Things like this, meeting other, Black women who, even if it's not necessarily the same disease, it's an autoimmune disease, so lupus, MS, all of these things kind of go hand in hand. So, there could be two patients with NMOSD, but if one of them is not a person of color, their treatment may be less than what their counterpart is getting. Or so, they're not going to understand that. They're just going to look at it as, well, we both have the disease and both of these things are available to us. Okay, well, that may be true. However, it may not be handled in the same manner.
Mm,
So support groups, like I said, forums like this, they definitely promote community healing.
Mhm.
absolutely, absolutely. What about you, Nwandi?
I mean, Mo said it all.
Mhm.
Forums like this, y'all, if you can get to wellness weekends, like get there, like conferences that are literally for us, right?
Mhm.
I think there is, when we talk about community healing, there's so much power in sharing your story amongst people who have similar experiences. Because again, back to that isolation piece, it literally will pull you straight out of that isolation.
Mhm.
And that's not
Mhm.
to say that you can't spend time, by yourself. Some isolation in some respects is fine, but
Mhm.
being able to connect, um, uh, like Mo was saying, peer support groups, just being in a
Mhm.
room where people are like, like you say, I'm so tired, I slept for 19 hours yesterday. You tell somebody that, like friends who love us, that they love us, but you tell them that and they're like, what, what,
What you mean?
what 19
Why you
hours?
sleeping like
I'm like,
that?
yes. And so you tell your peers that, or someone else who is living with a similar experience, it's like, yeah, girl, I
Mhm.
get it. And just watch what that does to your psyche. You're like, oh,
Yeah.
nobody gets it. And so I think it's just so powerful to be able to find yourself in spaces, like I
Mhm.
said, whether that is a conference, forums like this, so finding local support groups where you can share those lived experiences.
And what about like with like I kind of tell my patients a lot when I'm talking about physical therapy and occupational therapy and things of that nature. I'm really particular with where I send people because not all therapy is equal therapy. So I think the same can go in line with you. Not all therapy is going to be equal. So can you speak a little bit about like culturally attuned therapy? Like what does that mean?
That means finding a culturally, not just, we call like culturally competent, right?
Mm-hmm.
A lot of people know about different cultures, but are you I say you need to find a culturally responsive
Mm,
therapist or mental health professional.
okay.
Do they understand and do they know how to respond to our very unique set of circumstances? As Black women, if we're keeping it real, everything hits us harder and faster. That's
Mm-hmm.
just how it's been for generations. Everybody thinks we're the strong ones and that we wear capes. We need some people who understand, hey, you need a place where you can take the cape off.
Right.
Take it off. So yes, and also finding, you know, I'm big into like somatic practices these days. Like talk therapy is fine. I'm an advocate. I do it myself, but we also have what we call from bottom up approach. And so you have like, you have your prefrontal cortex, this is kind of like your logical brain, right?
Okay.
But then you have your subcortical brain, I think is what it's called. You might be able to tell me that, Dr.
Oh, yeah, yep.
But
Mm-hmm. Mm-hmm.
it's basically where like sensation, memory, emotion is stored. And so sometimes you can be aware, like you can say, I do A because of B, but you still have that somatic kind of flare up triggers happening. And so sometimes you do have to search for maybe some more somatic based interventions. So like your EMDRs, your which is eye movement, the desensitization. I can't remember what R stands for right now. My brain is shutting down. IFS, which is internal family systems. You have brain spotting. So all of these kind of reach beyond the logical portion of your brain. We are intelligent women. We know how to connect the dots. We need to be able to say, okay, we need to release some of this energy. And so I think because culturally, that is what a lot of our ancestors have been doing for generations and generations and generations, that is, we're a little more responsive to that.
Okay.
So, in a nutshell.
Yeah, yeah. And I think also kind of culturally, within our community, a lot of times there's the saying of, what happens in our household or in our house stays in our house. So I want to get everyone in the audience, I want to get you involved. Have you guys found it easier or harder to talk about NMOSD with your family and friends, and why not? Monica, what do you think about that? Have you found it easier or harder, like the more that you've gone, or as your, time has gone from, your initial diagnosis, have things changed a little bit for you?
Um, so it's always been easy with my family to talk about it. It was a little harder with my friends only because I feel like I was sick for so long that by the time I finally got a diagnosis, a lot of them were already over hearing me talk about being tired and all this other stuff. So, talking to them about it was a little hard. And I've lost some friends around the way, but as time goes on, it gets easier to talk about it. And plus, with it being a rare disease, the more it's talked about, the more well known it's going to become. So it's easier to talk about it now. But I have to remind my family a lot of times that, I'm sick. Like they'll come up on my left side and they'll be talking to me and they'll be like, "Why are you not looking at me?" And I'm like, "Well, I can't see you, but they're like, oh yeah, I forgot. Or, because, sometimes as moms, we try to be superwoman and, we're always going. So because of that, sometimes they forget that I'm sick until I've done too much and then I'm down for a few days or whatever the case.
Right.
But yeah, overall, I think for me it'll always be easy with family, but it's a little harder with friends, but gets easier as time goes on.
I would have to agree. And I'm gonna read some comments from the chat. I do not want to. I hate mispronouncing it. You guys see my first name. You probably think it's Jackie, but it's Jackie, or you might think it's Jakai, but it's Jackie. But Tamer or Tamaria, Miss Penley, she says, I don't have NMOSD, but I'm here to learn about it. I do have MS, and it's difficult to talk about with family and friends because of what I was before the diagnosis. I can definitely understand that. And then also from the standpoint of some of my family, I was okay with speaking about my diagnosis with, but my daddy, he was like a helicopter daddy. And so any little thing, like he was looking at, he was like, oh, your hands are shaking a little bit. Are you okay? Or did you get your infusion? What did your MRI say? Are you lying to me? So then it kind of makes me not want to talk to him as much and just be like, I'm fine, because I don't want all the questions to go with it. So completely understand that. And Claudette, she also has MS. She says it's easier now, and I feel I need to talk so they understand. That's right. Education, knowledge, all of that is key. But she says because fatigue is no joke. That's right. You really want them to understand that hidden symptom, that happens frequently. Shanteria, I'm sorry again if I mispronounce that. It's coffee It's been easy for me. I don't think my family or friends know me without NMO. Okay. I've been diagnosed over half of my life. So that's definitely more common and that we can see with NMOSD. A lot of times we do have either kind of more childhood or like pediatric onset, or we have kind of where we're diagnosed. And you know what, let's jump into the next section actually. And I'm like I said, knowledge is power. And I want everyone to, if you don't already feel comfortable about the diagnosis of NMOSD, to kind of be as knowledgeable as possible, feel comfortable speaking to your doctor about it. And if they're not able to give you the education that you need, you have programs like this for that. So I want to make sure that we're equipped with the right information to so that we can use this knowledge to kind of help protect ourselves. So I'm going to share, coming up, I'm going to share some key things about every Black NMOSD patient should know. And I want to try and keep it as plain and simple. So if I'm getting too, I don't know, too scientific, you guys let me know. I know some of the words on the slides that you're going to see are big, but I promise I'm going to break it down for you a little bit. All right, so let's just kind of jump right into NMOSD. So that stands for neuromyelitis optica spectrum disorder. So NMO is a newer condition, a newer diagnosis in the sense, but it's actually been recognized in the literature from way back in the 1800s. So in 1894 is when it was first identified that we've been able to find in the literature, and it was known as Devic disease. Even at that time, it was thought to be kind of a subset of multiple sclerosis. We knew that there were some similarities to it, but there wasn't enough there that would allow us to kind of separate it as a completely different diagnosis. For the longest, kind of with that, it was thought to be monophasic. So meaning that someone would just have one relapse and then that would be it. Now, kind of fast forward into the current future, we know that there's even other conditions called like MOGAD or MOG antibody disorder, where that's more typical, where you just have one relapse and then you don't typically have anything else. But over time, we notice kind of that relapses often will occur with NMO. And then in 2004, this is when we really knew that this was a distinct condition, when there was an antibody actually identified, so-called aquaporin 4. This was not discovered until 2004, you guys. And then it wasn't added to the diagnostic criteria until 2006. So there's a lot of different conditions and stuff that you'll see, and I'll talk a little bit more about it, that is why we call it a spectrum disorder. But you have all this time of it being recognized in the literature in 1894 to us knowing it's a fully distinct condition of its own in 2004. But it wasn't until 2019 that we've had FDA approved treatment for it. So just kind of, we're still, I feel like, in the baby stages of understanding and properly treating NMOSD. So where does it fit in? So like I was saying, for the longest, we thought that NMOSD was just a subset of MS. But when we eventually found, looking at the lesions under a microscope, they look different than MS lesions. So that was one way that I didn't let scientists know that this actually looks like this is something different than what we've seen with your typical multiple sclerosis lesions. And then also kind of being able to identify what those lesions look like, and then the cells that they find in those lesions are different than kind of some of the cells that are noticed, or immune cells that are noticed with multiple sclerosis. So again, letting us know that, okay, this looks like something different, similar to MS. And all three of us have had that experience of kind of one of our initial symptoms being the optic neuritis with NMO. It specifically targets the optic nerves, your spinal cord, but more so than what we see with MS, we also see when it is in the brain, we do see a little bit more brainstem involvement. So when we're looking at the MRI, the actual lesions that we see on the MRI look a little bit different for NMOSD. They're a different appearance. They might look more fluffy, is how I like to describe it. And then they're in different parts of the brain that are not as typical for what we see with multiple sclerosis. So to talk a little bit about kind of epidemiology. So what are the numbers looking like for those that are living with NMOSD? So it does primarily affect females. So 70 to 90% of people living with NMOSD are females. In children, I talked a little bit earlier about how we can see this kind of early and then also kind of see it a little bit later as far as for initial diagnosis, but it doesn't seem to affect females more than males in childhood. Age of onset is a little bit later than what we would typically see with multiple sclerosis. So with MS, we think of kind of age of onset around like 20s and 30s, but that gets pushed back a little bit with NMOSD. So age of onset is typically around 30, sometimes even in your 50s. And we're seeing more and more elderly people getting diagnosed with NMOSD, because a majority of them, a lot of times in that case, I think were just misdiagnosed with something else. I don't think, in my personal opinion, that they first developed NMO at 65 or 70 years old. I think they were misdiagnosed. About 80% of people living with NMOSD are seropositive. So we have our other 20%. Wait, is that right? I'm not good at math, y'all. 8, 9, yeah, 20%. Monica included in that bunch, who are actually what we call seronegative, meaning that when we're testing your blood for the antibody, aquaporin P4, it comes back negative. But that diagnosis with seronegative, we're really relying on your clinical presentation, what your MRIs and things look like. And that's really, really big with helping with that diagnosis. Yeah, we have Pam here, with diagnosed at age 64. Pam, if you don't mind responding, can you let us know if you had symptoms prior to your diagnosis, or when you were diagnosed, was that kind of close to your initial symptom? As far as for, is this something that's genetic? NMOSD and a majority of these different autoimmune conditions, including multiple sclerosis, are not genetic per se, in the sense that we're not passing down a specific gene that is saying you're definitely going to have MS. Most of the times it's sporadic. But if someone does have a family history, so Monica and Nawani, if you have, I don't know if you mentioned having kids, Nawani, but I have a 2-year-old. But with all of us, you know, our children are about an increased risk of having our conditions by about 3%. So we see that with both NMOSD and multiple sclerosis. Absolutely does not mean that they're going to get it, but they do have a slightly higher risk than they would if they did not have a parent or even a grandparent that had the condition. Now, when you're thinking about, I'll see a lot of patients and they're coming, they're like, oh, well, I have a cousin with MS, or, you know, a lot of times it's cousin. And I'm like, okay, is it like a first cousin? They're like, no, it's like my, you know, third cousin, twice removed. That doesn't play as much of a role there. But, you know, any increase in any type of autoimmune condition in your family can increase that risk. And then there are some particular genes that do also increase your susceptibility of, or your likelihood of possibly going on to develop NMOSD. And so as far as for kind of how common is it, NMOSD is rare, you guys. It is rare. I have been in practice for, it'll be 4 years this fall after I finished up my fellowship, and I have maybe 2 NMOSD patients, where I have multiple MS patients, but we still do see it primarily in the Black community. So NMOSD is more common in Black community as well as the Asian community. So it's definitely not as common in Caucasians. With that, that's what we can see with a lot of different conditions. I think, Nawani, you pointed this out, is that we oftentimes will experience, I guess, more significant disease. Our relapses might be a little bit worse than our white counterparts. Progression might be a little bit different. For MS, we don't typically see progression for NMO. I'll talk about that. But, you know, those are some of the things that kind of differentiate when you do see NMOSD in Caucasians or someone else. But when we look at, particularly for NMOSD, when we look at the outcome or the recovery from a clinical attack, this is similar across all racial groups. So even though the initial attack may be severe, how you recover from it is going to be kind of similar to what we would see with anyone else. So these next couple of slides, I think, are really important with understanding, how does NMOSD present? If you are experiencing symptoms like this, how can you better advocate for yourself? So knowing about these things will allow for you to push for more tests if you need to, or ask additional questions. So one common thing that we can see with NMOSD is where it's impacting the spinal cord, and we call that transverse myelitis. So with transverse myelitis, is essentially where you have an area of inflammation in the spinal cord. Now we can also see this with multiple sclerosis. However, the difference is when we're particularly looking at the MRI, if you look at the picture over there, and the little brighter area that you can see in the very center, that's the spinal cord there in the center. You have your vertebrae, or the bones, in the front part, and then back on the back part, that's like the bone that you can feel if you touch, like in the middle of your spine. But there, that dark line in the center, that's the spinal cord, and you'll see kind of a fluffy area of like, is kind of a bright area of brightness that's fluffy in the spinal cord. Now, in a patient with multiple sclerosis, that area of fluffiness, or the lesion, would be kind of just maybe one spot, one small spot. But typically when we're looking, and if I were to see something like this, my thought would go completely to, okay, is this possibly NMO, because of how long the lesion is. So typically we'll see what we call longitudinally extensive transverse myelitis, where more than tends to be more central, and then we see multiple layers that are affected. Oftentimes, whenever you have transverse myelitis, symptoms include spasms. You can have weakness in your arms or your legs, loss of sensation associated with maybe some numbness and tingling that can be painful. And limb weakness can be just kind of feeling heavy, or full paralysis, not able to move at all. And paralysis even down to might need to be intubated because even your lungs aren't functioning properly. And then anything that can affect the spinal cord can also affect your bladder and bowel function. So loss of bladder and bowel. These are things that we can see. Again, these symptoms themselves are similar to what we can see with multiple sclerosis, but it's oftentimes the severity of it and the response to treatment and what it looks like on an MRI that separates NMO from multiple sclerosis, if that makes sense. All right. So another thing, we've talked multiple times about optic neuritis. This is one of also the classic things that we can see with NMO, but we also see it with MS, as you guys have seen. So the thing that separates that, we have painful vision loss. That's kind of just the hallmark of it. As that optic nerve gets inflamed, if you think about it, it's attached to the back of your eye. So as you're moving your eyes, there's this really inflamed piece of tissue that it gets tugged around, and that can hurt. So painful vision loss is what we will call optic neuritis. But with NMO, the inflammation of the optic nerve is typically more extensive, similar to what we saw in the spinal cord. So with that, you can have actual blindness, whereas with multiple sclerosis, for me, with my optic neuritis, it felt like someone just kind of smudged my eye, and it was just a little bit dirty, and it was kind of blurry and hard to see. But that's a lot of times can be different with NMO, where again, people can have actual blindness. And then also optic neuritis can occur in both eyes, either at one time or at the same time occur in both eyes. So that's a big difference between the two there. And then one thing that is a hallmark for NMO that we do not see with multiple sclerosis is the clinical presentation of intractable hiccups. So if, suddenly someone will get hiccups, and, you get the hiccups and they go away within like 30 minutes or so, or you stop thinking about it. And then when you think about it again, you're like, oh, I'm not hiccuping anymore. That does not happen if there's a lesion in particular in the brainstem that can cause this. And associated with those hiccups that you can't get rid of, you can have nausea and vomiting. And then again, on the MRI, we will see specific lesions in a particular area. So that's a key thing. That's like a textbook presentation for NMO, but of course, not everyone will experience that. So the biggest thing is to recognize and be able to identify, I think, kind of the symptoms that you can see when we should be looking for NMO. When should we be checking for that antibody? or when should we be paying more attention to what your MRIs look like or what your clinical presentation is, the severity of your symptoms, to be able to get you in so that you can develop this comprehensive care, having like a patient-centered team approach. So all of that includes having your, I have on here MS, but your NMO, your neurologist basically, but also having, we talked a little bit about physical therapists, occupational therapists. I'm big on, I know a little bit about, treating for urinary symptoms or bladder things, but I don't know the everything. So I'm going to refer you to a urologist who does, or send you for pelvic floor therapy. So having this comprehensive care can help promote, again, communication, optimize your care, and then the goal is to enhance your quality of life. So let's jump into treatment. So we approach it in two different ways. So you have your relapse. So when you have this sudden onset of symptoms from inflammation in your brain, your optic nerve, or your spinal cord, we treat that with either steroids or what we call plasma exchange, or PLEX, or plasmapheresis. They have a couple different names. Now, a thing that separates NMO, again, from MS is that typically relapses with MS respond pretty well to steroids if we're able to get them into your system quick enough. With NMO, we might have a good response to steroids, but sometimes having a complete improvement, let's say we'll talk about optic neuritis, having complete improvement of your vision and different things may not always be the case. So then we need to move forward with plasmapheresis or plasma exchange. So for me, for my NMO patients, if I'm concerned about a relapse, oftentimes I'll give you some steroids, but because plasmapheresis is a whole process, but ultimately that's what I'm going to want to do to make sure we have as much improvement in your overall symptoms. We know that untreated, the risk for relapse is extremely high with NMO. And the difference, the importance with being on some type of treatment with NMO is because your disability, if you have disability, comes specifically from the relapse itself. So we talked a little bit about not necessarily having a complete response or complete improvement of your symptoms. And so over time, if you have a relapse here, then you have a new baseline. If you have another relapse, then that can affect you, in a different way, and that in itself increases possible or potential disability. Whereas with multiple sclerosis, outside of your relapses, in between your relapses, you can sometimes still have progression of your condition, and we don't see that with NMO. So again, really important for us to know and identify, is this something, does someone have MS or does someone have NMO? Because also some of the treatments that we use for multiple sclerosis can actually make NMO worse. So one of the medications that we use very frequently, one called Tysabri. That one in particular for NMO can make it worse. So we don't want to, be proud of us for catching things and treating you with high efficacy therapy, but then we're making your condition worse. So I check everyone for the antibody, regardless of what I think. Even if I think it's MS, I still want to rule out or rule in. If I think it's NMO, I want to do what I can to make sure we're not missing anything. So we talked a little bit earlier about how it took so long to, have adequate treatment for NMO. So we can say proudly now that there are actually, I know this figure shows 3, but there are now 4 FDA-approved treatments for NMO, and they work so well, you guys. They work really, really well. So it's literally been a game changer. Prior to these medications, there were other kind of immunosuppressing agents that we use that were kind of hit or miss. They work well for some people and then didn't work well for others. And then sometimes it will be difficult to get medications approved. So, having these medications that are specifically for NMO and seropositive NMOSD, but we find a workaround to get things approved for seronegative NMO. But these are the medications and stuff that we have, and there is a good time I would say to if you had to be diagnosed with NMO, now's a good time to be diagnosed with it because the treatment is good. So what do we do now? So we understand that there's an unrecognized burden of multiple sclerosis in the Black community. It wasn't until kind of more recent, within the last couple of years, that we were able to identify that that MS is the numbers of newly diagnosed people living with MS is highest in the Black community for multiple sclerosis. But we already know that there's the recognized burden of NMOSD in the Black community. And so that is why I'm so excited about programs like this, because I personally feel like even as a neurologist, I don't know as much about kind of support groups and things that are specifically for NMOSD within the Black community. So being able to bring those things to forefront so that we can increase awareness and knowledge within the community is really, really critical. So we want to be able to support identification of, education programs, peer support by neurologists for us as well, and especially family physicians, because they're usually going to be the first ones that you're going to with your problems. And then it also allows for counseling and assessment and therapy, and then the production of culturally competent videos. We want to see ourselves out there. These commercials, for these newly approved FDA approved medications for NMO, I want to see a Black person in this commercial. I want to see at least give me an Asian person. I don't want to see no white person in this commercial for a condition that doesn't affect them as much. So these are the things that we want, and we're able to that by getting the knowledge and the awareness out in the community. So I want to get my audience involved. I see that you guys have been, yes, representation matters. I see you guys have been busy in the chat, but what's one thing that you all wish your healthcare provider explained better about NMOSD? And while they're putting that in there, Monica, do you have anything that you want to add to that?
I don't know if, well, I'm not going to say nothing. I think that more doctors need to be aware of resources. Somebody from Guthrie Jackson found me on social media. I didn't know anything about them. I didn't know anything about any organizations or any type of support groups until people started finding me. So I think now, especially with social media and with all the resources available, I think doctors should give that information to their patients to help them kind of build their community and find support. And it may make it easier for some people versus having to try to find stuff on your own and not knowing whether what you're finding is something that's legit, because just because somebody has a support group doesn't mean that, it's the real deal. So
Right. Absolutely. While I'm waiting on those for you to in the audience to kind of give, if you have any a response to this question, there is a question in the chat saying I was taking Rituxan until February, then they changed me to Uplenza. Do you have any info on this medication? So all of the medication, I want to be kind of generic and definitely encourage you to speak with your neurologist about more about that medication. But in general, the majority of the medications that we have for NMOSD, they modify the immune system in a sense. So there's one that kind of suppresses the immune system, not the one that you're taking. It kind of suppresses the immune system by knocking out a subset of your B cells. But the other medications, including the one that you've just been switched to, they work on the immune cells that are part of the process of attacking where the antibody attacks your nerve cells, I guess I could say. And so it stops that process, and it basically attaches itself to a receptor so the antibody itself cannot attach to the receptor. And then that helps to prevent new inflammation and things that can cause a relapse. So in a nutshell, that's kind of how your medication works. With all of them, there are different pros and cons with them in regard to, and I think it all goes based off of your lifestyle and what works the best for you. They're all infusions, but when you get infused and how often you get infused is going to be a little bit different. So you definitely want to make sure that you're speaking with your neurologist about something that is going to be as convenient as possible for you, and possible side effects, or if family planning is in the picture. Those are the conversations that I would recommend having when switching medications or starting a new medication. Hope that answers your question without me going into too much detail specifically about the medication. All right. Well, I guess we'll move on right on ahead and still feel free to drop anything into the comments that you want. But let's move on to this next part where I would love for us to go more into about lifting up our own voices. I feel like we've been doing that, but I want to take time to learn a little bit more from each other and share what has really carried us, what brings us along. So again, feel free to drop your thoughts and questions in the chat. Again, the lecture part is over. I'm done lecturing now. We're back to just having a conversation. So, Monica, I'll start with you. What does self-advocacy look like for you when you're navigating your appointments or your treatment decisions? I know I kind of just added a little bit in that when I just was speaking, but what does it look like for you?
Um, it took a lot for me to be able to stand up for myself. Doctors can be intimidating, but doctors don't know all. Um, and that's why, a doctor is said to be practicing medicine because it's something that's forever changing. It's not something that, I mean, you can specialize in something, but even then, there's always going to be changes. But I think for a lot of us, and especially people of color, we already have a hard time when it comes to going to doctor and staying on top of your health and things like that. And then it makes it even harder when you have doctors that don't listen to you. But I realize that at the end of the day, a doctor works for you. And if you don't like what they have to say or you don't like how you're being treated, you can always go to someone else. And I will do that with a quickness now. If I don't like a way a doctor treats me or how they speak to me, I will find a new one.
Good for you. Yes, fire us in a heartbeat. And you find someone that works with you just like, we're with a therapist, you're going to seek out a therapist that you connect with, that you feel comfortable talking to. And the same should go for your healthcare provider. And it's the whenever we have that rapport, that only allows us more and to be able to kind of help manage you. I want all my patients to feel comfortable enough to tell me about all their symptoms. And even if it's something that I don't think might be related to your NMO, I want you to still kind of ask me so then I can help kind of guide you and do kind of patient-centered care, even when it comes to deciding the medications and stuff. At the end of the day, another thing I tell my patients is that at the end of the day, I'm about to move on to my next patient, but you're living in this moment, in this conversation that we just had. You're taking this home with you. So I want to make sure that all your questions are answered and that you understand everything. So if that's not being done, move on. Just like you would do with a hairstylist or anything like that, move on. All right, well, Nawandi, how would you recommend that patients prepare for meetings with their neurologist or any other specialist to make sure that their voice is heard, especially when you go to these appointments and you're feeling very anxious, like if you have new symptoms or if you're, newly diagnosed?
So I think one of my most practical pieces of advice is to write down your questions and concerns before your appointment. We know how getting in the appointment, sometimes it can feel rushed. Our brains are flooded with all these different questions, concerns, what's going to happen to me. And so sometimes if you give yourself a chance to just prepare a few questions ahead of time, when your mind is a little clearer, you're able to kind of think about, that symptom you experienced last month that you likely won't remember when you're actually in the appointment. And then after the appointment, you're like, dang, I forgot to say something about that. Um, bring a support person. If you're able to, hey, mom, dad, friend, whoever, bring them, especially when I know the question emphasizes when we're feeling anxious, bring a comfort person. Because not only do you have comfort, but you also have another set of ears and you have another set of eyes. So if you do forget to bring something up, They're like, hey, Mo, what about, what you were telling me about last month? You need to bring that up. So yeah, I think just writing down your question and concerns ahead of time, bringing a friend or bringing a support person and tracking your symptoms. I think we were just talking about that. Keep a symptom journal. So, because it can be a lot. I don't remember when my last hand trimmer was, but if I look at my journal, I can tell you exactly what day and what time because I put it in my journal. So I think those are three kind of just practical things that we can do. And use your voice. And if you haven't quite found your voice yet, um, I have hope that you will find it. And that also speaks further to the importance of having support when you're in these appointments.
Absolutely, absolutely. And having a voice, I think is so part. That's what being able to advocate for yourself. That is what it is. Having a voice, finding your voice. Mo, it sounds like you kind of found your voice a little bit early on. Would you mind kind of telling us a little bit more about your diagnosis journey, and then how have you needed to advocate for yourself while navigating your life with NMO?
So even in just the getting the diagnosis itself, when I had my attack of optic neuritis and I went to the hospital, the area that I lived in is what they would call low income. I'm in a low income area. And so a lot of people that go to the hospital are drug seekers or they're homeless and they're just looking for shelter. So getting care can be difficult with some of the hospitals in the area as it is. And when I went to the emergency room with the optic neuritis, one of the first things they did was drug tested me. And so, that makes it that's already making it hard because you feel like they're putting you in a box. And then also having any type of comorbidity. I'm also diabetic. So, of course, being diabetic, some of the same things can happen. You can experience vision loss or, the neuropathy and all those other things. And when I was trying to figure out what's going on, it was easier for them to say they felt like it was related to the diabetes because that's something that was already charted that I had, and it was like less work for them. But when they finally started doing all the exams and realizing that no, this is more than diabetes, then they had to do the work. And that's only because I kept telling them, like, I know the difference between some of the diabetic symptoms and some of the symptoms that I've been having, and they're not normal. So I need you to do the work. If it's diabetic related, it could be something new. Okay, I'll take that. But I don't want you to be complacent with the fact that I have a diagnosis already, and so no more work needs to be done. So that was a time where I had to find my voice and I had to speak up and I had to advocate for myself because had I not stood up for myself, they probably would have told me it was nothing but an anxiety attack or a panic attack or whatever the case may be and sent me home.
And that is just unfortunately the story for so many people, and a lot of people don't keep pushing like you, and they will just kind of agree with whatever that diagnosis that was given to them is, and then that's just it while they're continuing to get worse because they don't have that clear diagnosis. So kudos to you for pushing and and advocating. I would like to quickly talk about, if you don't mind, Wandy, because I think this is really big, and we spoke earlier about kind of grieving and just like dealing with your diagnosis and then processing everything after your diagnosis and all the nuances that come with it. We know that there, in majority of places, there is a desert for mental health specialists, like a desert for neurologists, but we also see that with mental health specialists. So how do you advise for patients to advocate for themselves to when it comes to their mental health, or to seeking out getting that additional care if necessary when they need it?
Yeah, I think that's something that we don't talk enough about, especially when we're in like our neurologist appointments, is asking for referrals. Like, hey, who do you know? like
Mhm.
advocating for like a more like whole person care. But also, I'm not sure who all, has a therapist or who has sought mental health care. But if you're open to virtual services, that opens up your options a lot. So, for instance, I'm licensed in the state of Georgia, but my
Mhm.
practice is 100% virtual. So,
Mhm.
anybody, whether you're in South Georgia or you're in North Georgia, you can see me. So if you're open to virtual services, I think that really can benefit. And like I said, just it opens up your options a lot.
Absolutely.
Also,
Thank you.
if you have the capacity, start your own support group in your area.
Mm.
So that you're addressing that need for care in your community. If it's not there
Hmm.
yet, maybe it's up to you. Maybe
Yeah.
okay. So
And I think one thing that you could also do is even maybe talk to your neurologist. Is there someone else that you think that I might be able to connect with that?
yeah,
And, of course, they would ask that individual separately, but to make that connection, just like when we do when we're mentoring someone, someone say, I have such and such who wants to do whatever it is that you're doing. Would you mind talking to them? Maybe we should utilize your doctors and stuff with that. That just came to my mind based off of what you said, but
yeah,
absolutely. And I
absolutely.
know earlier we were talking a little bit about setting boundaries, or at least I was talking about setting boundaries when I brought up my dad. Love him down. But how, and this is for both of you guys, how do you set boundaries around your help, especially when, they just want to protect you. They want to love on you. They want to make sure you're okay, but also you just want that independence. Some days you're like, please ask me how I'm doing, but other days you're like, wait a minute, I'm okay. How do you set your boundaries?
I have to tell my family to let me try.
Mhm.
Don't automatically come and try to do something for me. Let me try. If I try and I can't do it, or you see that I'm struggling, then you can help me. But it's already hard enough trying to feel normal. But let me feel as normal as I can. So just let me try before you run to try to be at my rescue.
Mm, yes, that's a word there.
Love it.
What about you, Nwandi?
So from I guess like a professional standpoint, I always remind my clients that boundaries aren't to keep people out, they're to keep peace in. And so I think a lot of it is being able to turn inward and recognize, okay, what do we need? And set boundaries based on those needs. So if
Mm,
Mo, it sounds like, a lot of us want to keep some source of like some sense of our autonomy and
right.
our ability to do things. And if I know that's important for me, then I can say, hey, friends, hey, family, I love y'all down, but I need y'all to bag back and let me do this. Right. So for me, it took my friends a while to grasp the fact that I just get very tired very quickly.
Mhm,
And so I know I need my rest. So when we're on vacation, I'm like, hey y'all, we got to build some nap time into this itinerary. They were like, nap, no, turn up, turn up, turn up. I'm like, no, I gotta go to bed. And so now, because I set that boundary, they build it into the itinerary without me even
mhm,
having to ask. So
mm.
speak up, but you have to know what you need in order to set those boundaries. Very important. Very important. Even with the
Wow.
people who love you.
Yes, yes. This is good, you guys. This is good. I wish we had more time. We've just been talking and chatting. I've loved all of this, and there were so many other questions that I have for you ladies, but we are kind of coming up on our time. I do know for everyone in the audience that there are other sessions, and they all are available on the YouTube channel. Please correct me if I'm wrong. We're ill, but if you didn't get exactly what you wanted from this one, because we've been just girl chatting.
I
Know
love
that there
it.
are some other sessions that you can look onto to see if there's other questions that you want to have been answered. I do want to point out some things that people have said. People were feeling it. Claudette, she said, yes, thank you. Bernice, that's good. Let me try. Carmi, absolutely. Let me do what I can do as long as I can. So when I can't, I won't have to worn you out. That's right. That's exactly right. It's like we're thinking about you. We want you to be comfortable and stuff. Caregiver support. That's a whole nother topic. And how we should support our caregivers and how they can best support themselves to help support us. One question we have, or maybe a comment from Tressa. I feel it's vital for medical professionals to read the patient chart prior to seeing the patient. Girl, yes. It helps the provider understand the patient. I have NMOSD, aquaporin P4 positive, so seropositive, another self-advocacy. Thus, the patient and medical clinician can work together. You are absolutely right. We have to do our due diligence too. It doesn't matter how many patients we're seeing in a day. I want you to walk in and feel like I know you, not only from I recognize your face, like, no, I know you. And if I need to use the chart to remind me about different things, that's what it's there for. So I'm really big on being as detailed in my notes as possible to help with that. One little small detail that you say to me, I want to be able to bring it up to you next time in case you don't remember talking about it or anything like that. So yes, thank you so much for that comment. Like I said, this has all been amazing. I do want to open the floor with a little bit of time we have left for any additional lingering questions that you all have specific to what we discussed, or if there was something else that other questions that you were hoping to have answered today that we haven't addressed yet, please drop them in the chat. And then let's see. I was looking to see if there is anything else. I tell my doctor that we are partners. That's right. That's exactly right. A lot of times whenever I'm seeing someone, I at the end of the appointment, I'm like, welcome home. I want you to feel like this is, I don't want you to ever feel like your doctor's office is a home away from home. But like I was talking about earlier, and we've thrown out these words of like comfort and support. I want to be a part of that support system for you to, make you feel comfortable to have these conversations. And as Jackie, not Dr. McEwen, that's what I want to with my doctor. My neurologist is my partner, and MS extraordinaire, Dr. Mitzi Williams, and I have an amazing relationship with her. And even during my appointment, I throw all my knowledge out the window, and I'm asking her things like, "Well, what about this? My leg is aching," and knowing that it doesn't have anything to do with MS, but I'm asking her just in case. So I hope that's the case for everyone. Let's see. Any other questions or any other comments, Mo or Nwandi, while we're waiting on some questions coming in?
I love y'all. That's it. This is not an easy thing to deal with. It's just not. And so I just want to remind you guys to give you guys or show yourselves lots and lots of grace, because the way you navigate this thing will look different from season to season. And like I wanted to echo what I said earlier is give yourself grace in finding your voice as well. Sometimes that looks different season to season as well. And as you use your voice, you can find yourself in communities like this. That's how Dr. McEwen got here. That's how Mo got here. That's how I got here. And so you get to be an intricate part of a beautiful community. So that's all.
Absolutely. Absolutely. We did have one question come up. Pam coming with all the good questions. Has anyone had to do breathing treatment because of the amount of steroids taken with NMO treatments? So we did talk about with a relapse, steroids are going to be our main play of doing things to kind of reverse the symptoms that you're experiencing with the relapse. If the steroids aren't working, sometimes we're giving extra steroids, or sometimes we're moving on to something different like plasmapheresis or plasma exchange. In the times where I have seen where breathing treatment is necessary, it depends on what the relapse is. So if it's a relapse in the spinal cord, it's like a transverse myelitis that is up high enough in the spine to that could potentially target your breathing. I have seen it in that cases. Also, in someone who has underlying asthma, we know that steroids and asthma, even though a lot of the steroid, the medications that you take for asthma or steroids, sometimes they don't play well together. So that can also be a reason why breathing treatments and stuff are needed in the case of getting steroids and stuff with your NMO treatments. Have you experienced any of that, Mo, where you needed breathing treatments or anything?
No, but they tend to stray away from steroids for me because of the diabetes. So
Mhm.
steroids is really if it's an emergency situation, but outside of that, I don't really do steroids too often.
Okay, okay. Perfect. Well, everyone, again, this has been so good. I wish we could keep talking. I feel like the conversation has been wonderful. Before we close out officially, I want to leave you all with a few key tools and reminders, so some practical things that you can carry with you after tonight. Because again, what we started here doesn't end here. We don't want it to end here. We want to continue to develop this community, especially with our NMOSD sisters. As you see, we have a lot in common with NMOSD, but it's still totally two distinct things, and journeys or stuff are going to be separate. And I feel like everyone needs their own platform. So we need our NMOSD sisters and brothers to have their own platform to stand on and help, raise awareness. So let's build and lean into this community that we've been talking so much about. I think one of the biggest things that I want you to take away from tonight is being able to advocate for yourself. You have to advocate like your life depends on it, because it literally does. It literally depends on it. I think one of the scary things about having NMO or having MS is just the unknown. And you don't know if you do have another relapse, how that relapse is going to affect you. So we want you to be able to advocate for yourself to get the care that you need to prevent any of that. And then in both investing in your total wellness. So mind, body, and spirit is all interrelated there. One affects the other, and we don't want to ignore any of it. I want to also remind everyone about the branded resource box that's available from We Are Ill. So this will go out to the first 50 attendees who complete the post-event survey. So that'll come directly to you. Fill out that survey. You'll input your address, and you can get that box sent to you if you're within the first 50 attendees. So with all of that said, again, I want to thank you all. We're going to end on time. I don't want to take up too much of your evening. Any quick final words of encouragement before we go out?
No, awesome. That's an awesome conversation. Again, it's just like like you said earlier, around that overlap, the similarities. Like even though I have I have mess, it's like as I'm listening to these stories, I'm like, oh yeah, that just resonates so much what I'm going through as well. So thank you so much for all those who attended. Again, another pub for that if you want to fill out the survey afterwards, not only for that, those first 50 respondents for that brand, that branded gift, but also just want to get your feedback so we can continue to make events that make sense and are valuable to you all. And make sure to follow us on Facebook, Instagram, and we're Illmatic, and stay connected on the future events that we're hosting. So thank you so much.
Thank you.
Thanks, y'all. Had a good time with you guys.